get started. We have lots to talk about today. Welcome everyone, and thanks for taking the time out of your day to join us this afternoon. We have a fantastic presentation lined up for you. I'm really excited to be welcoming Drs. Sarah and Roger Strasser to our conversation. I'd like to start with a few housekeeping items before moving on to a land acknowledgement. We're fortunate to have a really full room today, and as such, I'd like to request that everyone keep their videos and microphones off during the presentation. This will allow everyone to make use of the hide non-video participants feature, and that'll really highlight the speakers for you. We'll set aside roughly 10 minutes at the end of our session for questions, so make sure that you use the chat to share any questions that you might have. My name is Natalia Mason, and I'm the Community Engagement Specialist in the Division of Social Accountability. I'm joining you today from the College of Medicine's main campus in Saskatoon on Treaty 6 territory. As we gather here today, we acknowledge that we are on Treaty 6 territory and the homeland of the Métis Nation. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Like many of you, my life has been enriched and sustained by the care and stewardship of these lands by Indigenous people since time immemorial. Saskatchewan is a geographically diverse province, from the grasslands in Treaty 4 to the Canadian Shield in Treaty 10. People in the rural and remote parts of this province are routinely impacted by inequitable and inadequate access to healthcare. Knowing that more than 70% of Indigenous people in this province live outside of large urban areas highlights the intersectional impacts of this issue and helps us to align our efforts with the TRC calls to action that address health. For those who are unfamiliar, the Division of Social Accountability is a division of the College of Medicine dedicated to health equity, anti-racist education, community-based research, advocacy, authentic partnerships, and the health needs of underserved and marginalized communities. We engage with and learn from our communities to support relevant, meaningful, and impactful health professional education, research, service, and advocacy. This year, it's our intention to focus on different topics every month, each related to the health equity needs of our community. This month, we center our conversation around rural and remote health. For our presentation today, we are joined by two incredible physicians, advocates, and scholars. I had the good fortune of meeting Sarah and Roger at a conference in Vancouver last August. I had been told about the incredible work being done by Nawsum University, and I was hoping to make some new connections, so it felt incredibly serendipitous when I happened to run into them while I was wandering around lost on the UBC campus. Sarah and Roger hold a wealth of knowledge on the topic of rural health, and we are so lucky to have them here to share with us today. A medical graduate of the University of London, Dr. Sarah Strasser is a global leader in rural health and medical education. She has held academic leadership roles in Australia, Canada, Guyana, and most recently as the Dean of the Te Wataki Waiora School of Health at the University of Waikato, New Zealand. She is internationally recognized for developing innovative health professional training programs for undergraduate, postgraduate, and teacher training faculty development in medicine and interprofessional health. Sarah was awarded the Member of the Order of Australia in 2019 for her work in medical education and rural practice. She is passionate about family medicine, health equity, and encouraging youth to consider health as a career. Clinically, along with being a family physician, she has worked in public health and has a distinguished track record in research, most recently for the World Health Organization to inform the update of the WHO global recommendations on recruitment and retention for remote and rural health professionals. Professor Roger Strasser is a leader in the global reform of health professional education. Recognizing the importance of context and community in medical education and research, Professor Strasser has gained an international reputation for developing and refining novel strategies to educate health professionals in and for rural communities. As a result of his formative work in this field, Professor Strasser has become one of the world's foremost authorities in rural, socially accountable medical education, as well as a sought-after speaker and advisor. In 2002, Professor Strasser was selected to lead the creation of the first medical school in Canada in 35 years, the Northern Ontario School of Medicine. Nawsum U is the first Canadian medical school established with an explicit social accountability mandate to improve the health of people and communities of the region it serves. Among his many accomplishments, Professor Strasser has been awarded an honorary fellowship from the Royal College of Physicians and Surgeons of Canada for his far-reaching impact as a leader in medical education to meet the needs of rural and remote communities in Canada and around the world. So grateful to have you both with us today, and I will turn it over to you.
Thank you, Natalia. The topic is rural and remote health, community engagement towards the fit for purpose rural workforce. And I'd like to say that neither Roger nor I have any conflict of interest or reason not to be able to present this to you. Thank you. So what is rural? And in fact, what is remote? And many of you will instantly have an image in your mind, such as these. If anyone was seeing the news last night, you might have seen a struggling moose. This is one in particular in New Zealand, which kind of sums up the issue for rural health. And recently, the world turned around so that actually we no longer have the majority of the population in rural areas, but in cities. And so rural is basically outside big cities, outside regional centres, and it's often referred to really as a state of mind. As I mentioned at the beginning, we need to differentiate between rural versus remote and northern. So around the world, it's very interesting that we find that rural communities have more in common with rural communities, whether even across borders and geographical boundaries. And what we find is that access is the one rural health issue that unites rural areas. We find that the resources are concentrated in cities, that we all experience communication and transport difficulties, and of course, the rural health workforce shortages. So rural healthcare delivery is therefore different from cities, and certainly local services are much preferred. I know that the recent Taking Back Healthcare refers to access for every Canadian to be within 30 minutes. This would be a significant challenge for any rural community, whether it's because of the transport and geography or just the communication. And the ideal is certainly to have the specialists providing a support role for rural and remote family physicians and practitioners. And it's not regarded as a second-class community of physician or health service. I think there's one of the challenges for rural healthcare delivery is that you cannot assume that the patients want to travel either. And Roger has a story where two of his patients, when we were in practice in Australia, rather than catching a train and travelling 2 hours to Melbourne, preferred to go blind. So what does that mean the rural practitioners are? They are what we call extended generalists. They provide a wide range of services. They have a high level of clinical responsibility and often in relative professional isolation, which is being managed to a certain extent with increasing access to the internet and World Wide Web. But they also have a specific community health role and leadership within communities. And for those who are teaching students, you might wonder how you might present this to your students as being a comprehensive role, which is one of the exciting things that we'll be talking to you about. And just a quick word on interprofessional teamwork, and we'll pick this up again later. What is classical is that it is much talked about in the cities, but actually happens more frequently in rural communities. And this is because of the workforce shortage, but also because of community relationships and the networking that inevitably happens within the rural communities. And in particular, it is able then to respond to community needs. I'm going to hand over to Roger.
Yeah, thanks, Sarah. So just to continue the thread which we've been setting the scene and in terms of rural and remote health. Describing rural practitioners as extended generalists puts the focus on generalism. And you can see on this slide a couple of reports in 2010, The Future of Medical Education in Canada, MD Vision, emphasizes the importance of generalism really for all students who become physicians, and the importance of family physicians being involved in undergraduate medical education. And then the 2011 report was from a Royal College of Physicians and Surgeons of Canada task force. And I think this description of generalism really is one of the neatest ones I've seen. The three key elements are they are providing a wide range of services as part of a health team and addressing the health needs of the community, the population that you're serving. So let's move our focus now. We've looked at the context of rural and remote health. Now let's look at medical and health professions education. And the standard model of education really was set in 1910, with the Flexner report, that provided the basis for what's now still seen as the standard conventional model of medical education, health professions education, with the university campus basic sciences, and then learning clinical sciences in the teaching hospital. And of course, over the 20th century and into the 21st century, those teaching hospital academic health science centers have really grown and developed to the point where you have to be very sick or have a rare condition or need some high-tech intervention as a patient, even to make it into one of those hospitals. And this has been shown by research in this slide. This is the 2001 publication in the New England Journal of Medicine that showed that out of 1,000 people in the community, maybe 250 consult a physician, less than one actually makes it into an academic medical center. So if the medical students are learning their core clinical medicine in the teaching hospital only, then that's quite limiting and raises questions. And since the latter part of the 20th century, in the 1980s, there's been a growing discourse about what's described as the hidden curriculum in medicine. And these are some of the key points. If for medical students, and this applies also for other health professions, but if medical students, if their principal clinical teachers and role models are teaching hospital specialists, they want to be the best kind of physician they can, so they aspire to subspecialties, hospital-based specialties. There's generally a sort of sense often in what's published by in the health system, but also more generally in the community, that somehow equates hospital care with healthcare, and the people who need care are hospital patients rather than people living in the community. And generally, the message, unspoken, sometimes spoken, is that family medicine general practice is it's less complicated, and if you're not good enough to be a specialist, well, I suppose you can become a family physician. And there's a sense really that becoming a rural practitioner is the ultimate failure. The geographical narcissism is the concept that the city sees the rural areas as being there for the aggrandizement of the city. That's the narcissism bit. And that does feed into a collective inferiority complex that often is quite evident in rural communities. So 1910 was the Flexner report. 2010, there were many reports, including, I've already mentioned, the Future of Medical Education in Canada, MD Vision. But I'd say this one, the Lancet Global Commission report, Health Professions for the 21st Century, was the most influential one. And it presented the vision, the expectation that health professions education should have the goal of producing transformative and interdependent professionals whose focus is on achieving equity in health. Now, to actually achieve this, the message was there needed to be substantial instructional and institutional reforms and enabling actions to that. But as I said, this was a very influential report, and many changes in medical and health professions education have followed from this report, although the impact is still really to be seen across health professions education. Now, the focus on health equity is consistent with the concept of social accountability that the World Health Organization defined in 1995 for a medical school. Everything the medical school does, education, research, and service, should be addressing the priority health concerns of the population that the school has a mandate to serve. And I'd say that was very influential in the 2010 report that I mentioned from the Lancet Global Commission, but also in 2009, the World Bank defined social accountability as being more specific and with the term civic engagement. Let's call it community engagement, where the community has a role in holding public officials and service providers to account. That's real social accountability. So, okay, saying that with social accountability, the focus is on addressing the priority health concerns of the population. How do you determine those? Well, in the year 2000, the World Health Organization published a discussion paper that included this partnership pentagram. So the basic concept is that, well, policymakers make policy, and they may seek input from health administrators, possibly even health professionals like nurses and doctors and others. And sometimes, and actually often, academic institutions in one way or another, universities have some input, but most frequently communities are not really included. And so the notion of the partnership pentagram is all 5 partners sitting around together and identifying what the priority needs are for the people to then design the system to address those. Now, there's been work actually in this country, specifically in British Columbia, where colleagues have actually taken the partnership pentagram, and they've identified that there's actually a 6th partner they call linked sectors. So these are local businesses, so for-profit, not-for-profit, other agencies that actually are not really covered by the other 5 partners. So they have the Partnership Pentagram Plus, and they have been working in British Columbia. It's in rural communities and Indigenous communities, and bringing all of the partners around the table to effect health system redesign. And they've recognized that sitting around the table at the local level, the system looks a certain way, but at the regional level, it's not quite the same. And then at the provincial level and national level. So they've actually connected these levels in the work that they've done. And this is the RCCBC, is the Rural Coordination Centre of British Columbia. So I'd encourage you to follow up with the work being done in British Columbia around making use of the Partnership Pentagram Plus to actually make a difference for the delivery of health services in remote and rural communities. Now, all of this really talking about education and training is ultimately about having a fit-for-purpose health workforce. Sarah talked about the most recent report recommending that everybody in Canada should be within 30 minutes of accessing primary health care. So it's certainly about access to high-quality healthcare close to home with the right, so a health workforce with the right skills, right care, providing the right care in the right place at the right time. But it's also about the mix and distribution, and that's between health professional disciplines and within medicine, and also generalists and specialists, primary care and other levels of care, and geographic mix and distribution. And so I think that the notion of a fit-for-purpose health workforce is important really in framing the discussion and looking to improving the access to healthcare and the quality of healthcare that people receive. But we're talking about education, particularly medical education. And so let me just talk about, in the context I've described, the Flexner report through the 20th into the early 21st century, originally the idea of rural medical education came up because there was a shortage of rural physicians. In fact, in Minnesota, in 1972, the Minnesota legislature threatened to cut the funding to the University of Minnesota if they didn't produce more rural physicians. And a chap called Jack Verby decided, okay, let's put medical students in rural communities for a whole year. And that was the beginning of the Rural Physicians Associates program. Still continues, and now many of the the clinical teachers in those rural communities, of course, are graduates of RPAP. And that really set a tone for the future developments in rural medical education. Fast forward to the present day, a lot of research, much greater understanding, and certainly evidence that that idea actually holds true. Having medical students and other health professional students actually learning in rural communities increases the likelihood that they'll choose a career as a rural practitioner. But more than that, we now know that rural practice requires a specific range of knowledge and skills. And actually the rural setting is a great place to learn because it's the hands-on experience, seeing a wide range of common conditions and the opportunity to develop procedural competence. And so the rural LIC stands for Longitudinal Integrated Clerkship, which I'll say a bit more in a minute. But essentially, we now know that rural-based longitudinal integrated clerkship has many educational advantages. And the basic concept is that the students, they spend a whole year based in family practice in the rural setting, and they see a wide range of clinical problems over time. And it's all about continuity of relationships between patients and students and with patients and with their clinical teachers, and also in terms of their curriculum. So they're covering the core clinical disciplines, not in a series of blocks, but in a holistic and of course family practice community-based way. And so during that year, the students gain more sense of confidence and competence and graded responsibility over time. I'll come back a bit more to the experience with longitudinal integrated clerkships as we go forward. But let's now turn our attention. Natalia talked about, she'd heard things about Northern Ontario School of Medicine, now Nossum University. And so let's talk about, share with you some of our experience from Nossum. The school was established with a social accountability mandate. That's a commitment to improving the health of the people in the communities of Northern Ontario, and also a commitment to innovation, and of course opened in 2005. Distributed community engaged learning is the distinctive model of medical education and health research that Nossum developed. Distributed means multiple sites. Now it's over 90 different sites where the students, the residents, the other health professional learners may undertake part of their clinical learning. Of course, to do that, they need to be connected electronically, and so it relies on electronic communications. Nossum has an extensive digital library service. So really for students, for residents, faculty members, community members, if you have internet, you have access to educational resources and information, pretty much the same as if you're in the big city, like in a teaching hospital environment. But the centerpiece of distributed community engaged learning is community engagement. And I'll say a bit more about that shortly. But I want to show you this slide, which is actually a visualization of 90 plus sites. The green is the whole of Ontario, and Northern Ontario, the border is sort of around here somewhere, I think. But you can see some of the 90 sites are not in Northern Ontario, but the majority are. And the color coding is different stages and different education programs of Nossum. For the MD program, students in their first year have 4 weeks living and learning in Indigenous communities. This is an immersive cultural experience for the students. They live in the community, and they're learning from the community about the history, the tradition, the culture, the social and the health issues. And that includes these communities here are fly-in, fly-out communities, First Nations, remote First Nations. And then in second year, students have 2 4-week immersion where they're in smaller rural and remote communities attached to the health team. So that's a clinical experience that then prepares them for the longitudinal integrated clerkship. So all the Nossum students participate in what we call the comprehensive community clerkship because of the active involvement of the community. And there are 15 sites across Northern Ontario, not Thunder Bay, not Sudbury, but 15 other sites where the students are living for the academic year, the third year, the principal clinical year. So they're living in the community and they're based in family practice and they see patients. So you might say the curriculum walks through the door. The first patient might be pregnant, that's obstetrics. The next patient might be a child, that's pediatrics. And the next patient might have a surgical problem. So the learning outcomes that are set for that year, the principal clinical year, the comprehensive community clerkship, just the same as in the other schools in terms of the 6 core clinical disciplines in medicine, but the students are learning their core clinical medicine from the community family practice perspective. And the research we've done has come to show that the development of the professional identity of the students is really progresses during this year, and it's through their interaction with patients and as the students really become part of the health team and focused on caring for their patients. So within a couple of months, they think and talk about going to work rather than going to study, and focusing on their patients is that sort of social accountability mindset, improving the health of the people they're serving, and a service orientation. And of course, the principal clinical teachers and role models are generalists, family physicians, and other members of the health team. So that's all of NOSM students have that comprehensive community clerkship. It's actually only in the final year, the 4th year, where they have intense direct teaching from specialists and subspecialists in the tertiary care hospitals in Thunder Bay and in Sudbury. And then after that, NOSM provides residency training in family medicine, multiple streams of family medicine, and 8 other general specialties, Royal College specialties. And you can see also there's a range of other health professional programs that NOSM contributes to health workforce education across Northern Ontario. Let's come back now to community engagement. I said we'd talk a bit more about that. The centerpiece really of community engagement is interdependent partnerships, is working together for mutual benefit, and the role of community is very important, helping to make the student, the residents, and their families feel at home in the community, so that they want to stay or come back after they've completed their education and training. And they also contribute to the students' learning in terms of the students appreciating the social determinants of health at the local level in the communities. And there are lots of other ways in which communities benefit in terms of education and research activities and community capacity building, including actually economic development. So it's easy to say community engagement, not quite so easy to do, and it's really important that true community engagement, where it's based in the community and led by the community, that's a continuous work in progress. And there have always been naysayers and doubters, so challenging the assumptions and always listening and learning and seeing what are usually put up as barriers as actually opportunities, the geographic, linguistic, social, cultural diversity as opportunities, really. And it is about working with the community, empowering the community and supporting the community in having this active role. And that's an ongoing process through connection and reconnection. I mentioned formalizing on the slide, formalizing the role. So NOSM progressed quickly, really through multiple collaboration agreements between the school and community organizations, health services, really right across Northern Ontario. This is a picture of the formal signing of the first of those agreements outside Thunder Bay or Sudbury. This is in Sault Ste. Marie, and you can see this individual was then the CEO of the hospital there. That's the mayor, that's the chief of the medical staff, the local member of the provincial parliament, and of course that was me. And this sign that you can see behind that was, of course, unveiled at the signing ceremony, which was a public event. And then the sign went outside next to the sign that told you at the Sault Area Hospital. And actually, this sign was about 3 times the size of the Sault Area Hospital sign. So very important that it's very important not only to formalize relationships, but make sure that people are fully aware around the communities. And that's even more so when we're talking about Indigenous people and Indigenous communities. So NOSM started actually with a curriculum workshop in Sault Ste. Marie. We ended up having over 300 people from across Northern Ontario, including 50 Indigenous people. And it was clear to me at that getting started in the North gathering in Sault Ste. Marie, that if we're really going to be able to provide what Indigenous people were looking for in their medical school, we need to have a separate get-together of Indigenous people from across the north. And that was the Follow Your Dreams workshop. We came to Wushushikonnagam First Nation about a few months after about 5 months after when we were in Sault Ste. Marie, and we had over 100 Indigenous people at this First Nation. We spent 3 days in small circles and large circles, listening and learning and understanding what was important for the Indigenous people. And the Follow Your Dreams report really provided the framework for the development of the Indigenous dimensions of NOSM. And over the years, we regularly would check back with these kind of community partnership gatherings. I should say that in the Follow Your Dreams, one of the key recommendations was having an early immersive exposure experience in the communities. And so that's what we do with all first-year medical students, as I mentioned before. And actually, the next time we came together was in 2006, which was the Keeping the Vision. And that was important because the students had just started, and the community, people from the communities that hosted our students actually shared their experience of having medical students. And even more important, that we demonstrated that we were serious about working with and being guided by the Indigenous peoples in Northern Ontario. You can see we've had regular gatherings since then. In fact, this gathering together for life and well-being in 2018, we came back to Wushushikonnagam First Nation where we'd been before, but also been a series of gatherings that are more focused on Indigenous research. Okay, Sarah talked about the interprofessional teamwork. What we found is that's important in terms of the education training model. And so with the patient family in the centre, having clinical teachers, not just physicians, the whole range of the health team, with medical students, postgraduate learners and other health professional learners is really works very well. And it works because having two learners is better than one. They teach each other multiple levels from different health profession disciplines, actually enriches the experience for everybody. It is important to keep the focus on the learning needs of all of the students and residents who are participating. And yes, there are challenges, not to overload any clinical setting, and there are logistic issues around space and so on, but it's worth it. And having the active community participation really adds value with integrated clinical learning. So just sharing some of the outcomes with NOSM. After 10 years, we did a review of the admissions process with a social accountability mandate. We aim to reflect the population distribution of Northern Ontario in each class, quite successful. Out of over 2,000 applications for 64 places, 92% of the students have grown up in Northern Ontario. The other 8% come from remote and rural parts of the rest of Canada. And the 40% remote and rural is about right for Northern Ontario, 22% Francophone, about right for Northern Ontario. Indigenous 7% was below our target. So since that review, the admissions process has been tweaked, and now it's 12% of the students are from Northern Ontario. And the grade point average 3.7 shows that even though we have an admissions process that favours applicants from Northern Ontario, remote, rural, Indigenous, Francophone, the academic standard of our students is just the same as other medical schools. So what about the students' experience? Well, these are quotes from various studies that we've undertaken over the years. I think the top one really sums it up from the students. You don't know it until you live it. And it's definitely fair to say that one at the bottom, you won't be it if you don't see it, are two really key drivers really in this, in valuing the students' learning in community settings and with active community involvement, the community engagement. So where are NOSM graduates? Well, after 10 years, we followed up. We've been following them all along, but we published after 10 years, 77% of NOSM graduates are in family practice, another 14% in general specialties, so 91% generalists. The 9% subspecialties, dermatologists, radiation oncologists, neurologists, they're important to us because it shows that if NOSM students choose one of these subspecialties that are very competitive to match to and in CARMS, then they're successful. And it's important in another way because we need those subspecialists in Northern Ontario, and they are returning to serve people in Northern Ontario. The bottom half of the slide is about residents, trainees, and it shows that those who did their undergraduate and their postgraduate in Northern Ontario, 92% are practicing in Northern Ontario. So having reflected on the experience in Northern Ontario and looking at research around the world, I've distilled this concept of immersive community engaged education. So immersive means the students are living and learning in the community and for a prolonged period, so they actually become part of the health team. And as I said before, their learning is really driven through their intense interaction with patients and their genuine, authentic relationships that the students develop with people and in the community and with colleagues and other members of the health team. And so that really does contribute to success in terms of producing the skilled, fit-for-purpose health workforce. I'm going to hand over now to Sarah again.
So thank you. And in line with the phrase, you won't be it if you don't see it, we've also learned that the medical students and then the residents need a facilitated generalist career pathway to follow and actually to be encouraged into it. So at the various stages you can see here, listed here, and even earlier than rural high school, promoting health careers is important. And as we go through the different stages, being able to address the issues and present it as a complete pathway, then we find that we're more likely to be able to attract and retain rural physicians. So this is a graphic of that. And I think for the community, the benefits is that there are increased opportunities for the attraction, recruitment, and retention. And of course, as the learners grow into being mature physicians, many of them look for additional career opportunities. And if they can stay in the community, then they are more likely to stay, full stop. And that includes research. So the benefit for the community here is if they're undertaking some research, they're answering questions that are of importance to the community in improving health outcomes. So to draw to an end, we'd like to just present the next slide, which is the essentials for success. So the active community participation is a very strong sticking factor for physicians, and the focus on population health needs not only motivates the learners to learn, but obviously helps improve the community health outcomes. Where the definition of success for these programs needs to be defined by the programs, not imposed by others. And that's through developing the vision, mission, and values with the community. And a key component of this whole program is not only that we maintain the standards and quality of the physicians and the health services, that we actually challenge conventional wisdom. And so we bring this to an end in time for the questions, I hope, just with a number of references that you may be able to like to look at. I'll just go back to the previous slide because you're not going to be able to read that at this point. Thank you very much.
Okay, I believe that Natalia has all the references, so we'll be able to share those with you for those who are interested in that. And we'll stop sharing the screen now so that we can open up for questions, comments, discussion.
Thank you so much to the both of you. That was fantastic and just like illuminating. And I also can't believe that we were able to cover so much content in that amount of time. We are actually joined today by Preston Smith, the Dean of the College of Medicine. So I just invite Preston to give you a quick welcome before we look at some questions.
Great. And Natalia, can you put my video back on? Just
Gotcha. Did that work? There we go.
Yeah, so I'm really I'm really happy, first of all, to welcome you and thank you for putting this presentation on for us today. But particularly, it's just a pleasure to see both of you. For the rest on the call, I've known Sarah and Roger for, I guess, pretty close to 10 years, and certainly had visited at nauseam a couple of times at their Iceman conferences, or at least that was the name of them at that time, I think. I also sat around the AFMC board table with Roger for about 6 years, I think, or 5 years that we overlapped there. Yeah, I was using your data with the government on Wednesday of this week with regards to NOSM's experience. So there's a lot of, I got a question for you. I'm actually, as usual in this job, supposed to be in two places at once. I'm also attending the council meeting of the College of Physicians and Surgeons, so I'm going to go there shortly. There's a lot of talk about rural streams or primary care streams or both. As you know, Queens is putting forward a model of 20 seats that's a primary care stream. We just saw the Alberta government yesterday announce $1 million for planning on 2 rural regional hubs associated in the north and the south, of course, associated with the 2 medical schools. So I'm wondering, is there any literature or experience or your opinion, if not evidence, about the success of traditional medical schools operating rural stream programs or primary care programs?
Yeah, I would say that the most literature on that comes from Australia, because the Australian government, going back now 20 years plus, has been funding medical schools to have university departments of rural health and rural clinical schools, and built into the funding the requirement that the students actually have a certain amount of their education in the rural setting, as well as having much of the funding supporting rural academics. So that's a place to look for the literature. It's not one of the references, but I can send you an article I did recently for the Medical Journal Australia that sort of puts that together. The issue, as I highlight, is that it shows, yes, rural background students who then have the rural clinical school experience more likely to go into rural practice, and the same for urban background rural clinical school more likely to go into rural practice. But the whole pathway, as we've described it, hasn't really been, it's been defined and is now being implemented, but hasn't really yet been researched to the point of having academic publications. And that's really what we're recommending now, based on all of this work, starting in the rural, the underserved communities, encouraging young people in those communities to see a future for themselves that might include a health career, and then supporting them, helping along the way in this pathway into university, into medical school. And then a lot of their, if most of the medical education occur in their own community, one like their community, at the undergraduate and then at the residency program levels. And then beyond that, transition to practice, supporting the transition into the real world of as physicians, not just family physicians, other general specialists as well. And then professional development and opportunities for different career pathways. So the whole, if you like, cradle to grave approach, there've been research that looks at bits of that, but the whole pathway is not, there isn't a specific publication that I can point you to, Preston. Sarah?
Well, the WHO guide for recruitment and retention in rural and health professionals refers to the fact there's little evidence to make it a strong recommendation, but certainly experience has been very powerful. And the keys to success is that the funding needs to be ring-fenced to actually be in the rural communities, rather than the Central University being able to draw at will as funding changes to meet their other needs, and also that that it's not just a case of picking up the curriculum from the city and dumping it in rural, because guess what? The students do what they need to do to pass their exams, and if they have to spend their whole time in the hospital and never go out into the community, that is what they'll do, and they'll turn out just like any other urban trained student or resident. So it has to, as Roger mentioned before, is that intense relationship with patients, the role models, and being comfortable about living in the community that will draw them to stay. And that's particularly where community engagement comes in. Thank you.
Thank you.
Thanks for your question, Dr. Smith. So I'm also going to invite everyone to turn the cameras on if they would like now, and show your lovely faces to Sarah and Roger so they can see that we've got a whole host of people here. I also see that there are some hands up and people have questions. So I'm going to go to you first, Lynn. Go ahead.
Bonjour, thank you. I'm coming from the unceded stolen lands of the Squamish, Musqueam, and Tsleil-Waututh nations. That is BC, as our English terms, that's BC. I work and play here in the downtown east side, Vancouver. I've been working with Health Canada for well over 20 years as a patient and a researcher and a researchee. And I'm also Indigenous. I am trying now to have my leadership and you guys understand that when you put us under that same umbrella, we don't follow. Indigenous health is separate from Canadian health, but yet you umbrella us under that same umbrella, same silo. Why are you guys doing our research and holding our information at in Health Canada? We don't have the same health care as the rest of Canadians. I don't know if you guys realize that. As for rural, when you're coming into our communities, you're coming in with your white ideology and the way you were trained. I'm trying to change this. We have our own Indigenous people. We have our own doctors. We have our own healers. We have our own sweat lodge holders. I want at some point for any of you physicians to prescribe me a sweat lodge or my elder, not a psychiatrist under fluorescent lights and concrete. We don't function under fluorescent lights and concrete and steel. We are land-based people. Once you guys get that, maybe then our healthcare system will change for rural and First Nations people. Up until that point, you guys are umbrellaing us under what you have as Canadians. We now need to look at our healthcare system for Indigenous people, by Indigenous people, because the way we do research is very, very different than what you guys do. Thank you, Miigwech OCM.
Yes, thanks. So we are speaking to you from the same unceded territory known in Canada as British Columbia, because we're helping the Simon Fraser University prepare to establish a medical school, and we're certainly hoping to work with Indigenous peoples, First Nations, Métis across the province to make real what you're talking about. Our email addresses were on the slide, so if you'd like to connect with us directly, we'll follow up with you then.
Thank you. Mateen, would you like to go ahead?
Thank you very much. I did put a question in the chat, and I think Roger and Sarah, you pretty much addressed most of those little bits of pieces that I requested there. So I'll just ask another question directly. Thank you so much for a simply excellent presentation. Now, is it possible to have, at least in some measure, a copy of your slides? I found some fascinating quotes there and also just a wealth of information and data. So that would be extremely helpful. I should introduce myself briefly. I'm serving as the provincial head for anesthesiology in Saskatchewan. So that is my lens, and strategic planning and thinking is my portfolio as well for delivery of services. So I have a particular interest in systems thinking and systems design. I think the way our current system is designed, it is producing the results that we see before us. We have a critical shortage of family physicians. We cannot retain physicians in the rural areas, and there is overload of the tertiary sites. So with that in mind, there are different routes that have been advocated for bolstering the provision of services in the non-tertiary care sites. Now, I'll list some of them. I'm sure you will probably agree with me that all approaches are valuable, but I'm particularly interested if you place hierarchical priority on any of these approaches as the biggest bang for the buck, so to speak. So some of the things that are out there include iterative, regular, and shared health human resources planning. We have to know what we need before we can plan to put where we need it. Another is payment models. You design a system, you don't incentivize rural healthcare delivery, and it comes at a financial penalty or a cost. There are many jurisdictions, I think Australia included, if I'm not mistaken, where rural service is incentivized by payment design. Another is distributed medical education with a deliberate focus, as was the focus of your talk today. And lastly, I'll mention a rather novel conception of communities determining medical school intake. So they identify the need, and there's a return of service tied to that need. You get into med school, you bid for that particular seat from that particular location. So I wonder if you think there are approaches here which are probably worth it for the magnitude of the effect that they cause. Go ahead, please.
Am I speaking first?
Yep.
Okay, so let's take the last one first. Yes, that works. So in the Philippines, there's a medical school that's been going for over 40 years now, where the community chooses individuals. They actually have what's called the step ladder approach. So the community chooses individuals who go to the school, they train as community health workers, they come back to the community, they serve the community. Then some are chosen and trained as nurses, come back to the community, serve the community. Some are trained then as physicians. They have an over 90% retention rate, not in their community, or at least in rural the Philippines. And this is a country where something like 60% of medical and nursing graduates leave the country the day after they graduate. So yes, that model works. And of all of the other items, I was going to say the place to start is in the communities. People in the communities, they know what the issues are. And so adopting the Partnership Pentagram Plus approach, as in British Columbia, in the remote and rural communities with the Indigenous communities, that's likely to be much more productive. The funding side of things can't be ignored, and definitely needs to be addressed in a way that doesn't distort the system. So it's getting the balance right. I mean, by and large, what motivates physicians, other health professionals to live and work in rural communities, it's about people and relationships. It's about feeling at home, feeling valued by the community, feeling part of the community. And in fact, a colleague from Scotland did a study last year in the United States, looking at the top performing rural hospitals in the United States. And of course, it's all about money in the United States. And just, I think, her surprise and others, she found that the top performing hospitals, what the staff said was they stayed there. They knew they could get more money somewhere else, but they stayed there because they felt valued by the institution and a part of the community. And so they're the sort of key elements really to focus attention.
So I'll just add that, again, in the WHO recommendations, we have moved to bundling of all those aspects. That it does need to be individualized as much as possible to the individual healthcare practitioner, but that working out what they need according to the stage of their career or family is the way to go. with a total bias of having kind of pulled it together, I would recommend having a read.
Thanks so much for that. So I'm cognizant of the time, and I also want to make sure that both Tara and Veronica have a chance to ask their questions. So go ahead. Dr. Tara Lee is the Associate Dean of Rural Medicine at the University of Saskatchewan.
Hi, Roger and Sarah. Can you hear me? Okay. I have so many questions that I'm not even going to ask a question. I think I'll just endeavor to come to you and take you out for breakfast, lunch, and supper, maybe for 2 or 3 days, because that's how long I think it would take for me to get all of my questions answered. I just want to say hello, introduce myself. I'm Tara. I would really love to meet both of you in person. Roger, I've seen you at conferences, and you actually gave me your business card, because at one point when I was the SLIC director for the U of S just up until December. And when I was at LIC conferences, thinking of, because I started the LIC in Saskatchewan, and thinking about it, I was always going to your sessions. And so at one point I came up to you and said, can I call you? And you gave me your business cards, and I never actually did, but I'm going to do that this time. So thank you very much. I was smiling throughout your presentation. You were singing my song. I just really enjoyed it. And thank you for all of your dedication, knowledge, and sharing of that with us today. Thank you.
Thank you for being here.
Veronica, would you like to ask a question?
Sure. I just thought we were running out of time. So thank you very much for your presentation. Very much enjoyed it. I had worked in Northern Ontario, so I'm quite familiar with those areas, and had worked as the site director for the Indigenous residency program out of UBC. So had some of your graduates come in and work with our program as well. Currently now at Saskatchewan, part of Northern Medical Services. So one of the concerns that we constantly have, and I'm just wondering how you manage some of the problems when we sort of plot people into these communities. And even though we talk about relationship building, the reality is that there still is a fair amount of cultural tourism that occurs, particularly in Indigenous communities. Often the physicians are sort of relied upon as being from the community, but we know they really are not from the communities, and yet are sort of the spokespeople. And there's a lot of modeling that happens. And so the concern, I think, as Lynn had kind of raised as well, we're really modeling a system that doesn't really fit in with our system. And so, and despite the fact of community engagement, there is a limitation on what influences are occurring, or what capacity there is for influence as well. So I just wondered, how are you kind of evolving some of those pieces? I mean, I love the concepts. I think they're great. And I think, I guess I feel like I know that those are things that you think about as well. But I wondered how you're addressing that and doing it.
Very quickly, I mean, all the points you've raised are really relevant and important, as with Lynn as well. ReNOSM was approached some years ago now by the Matawa Tribal Council to work with them to develop a remote First Nation stream in the family medicine residency program. And that's very much co-designed, co-delivered, and really led by and we started with Yabamatung First Nation, which otherwise known as Fort Hope. So a remote community about 2 hours flight north of Thunder Bay. And, it's slowly growing and developing, but that's an example of moving, shall we say, to the next level and picking up the issues you raised.
Mm-hmm. Thank you.
Well, with that, I will just once again extend my thanks to Drs. Sarah and Roger Strasser for joining us today. We're so appreciative of your time and your wisdom. I'd also like to thank all of our USask community members and our Greater Saskatoon community members who have joined from near and far to learn with us today. If you are interested in staying in touch with the Division of Social Accountability, I put a link in the chat that will help you sign up for our newsletter. Next month, we're going to be exploring topics related to Black History Month. There is also a link to a survey for today's presentation, but we'll be following up with an email including resources, the link to the YouTube recording, and that survey link as well. So make sure that you make use of those as well. Thank you and enjoy the rest of your day.